What's happening here? Why is it affecting Black and brown women at such a high rate?
Ooh, loaded, loaded. Where do I even start? We make up 51% of the population. The funding in research is around 1 to 2% for women's health.
You'll get a research call that gives you 2 weeks of a deadline to get a very big research application in, but they had no people of colour to inform what their research is. But Neelam, can you just get us different people from different communities?
She looked at me, she goes, every woman thinks she bleeds, but in reality, it's only an egg cupful. And I just looked at her and I said, how big is this egg cup?
This whole wanting to control the fertility of Black and brown people.
Where we reframe our work at Sisters is not just reproductive health anymore, we call it menstrual maternal justice.
They often say, oh, we're treatment resistant. No, we're not necessarily treatment resistant. The treatment wasn't made for us.
Today on The Social Corner, we're diving into an issue that shapes millions of lives, yet remains underfunded, under-researched, and too often dismissed: female reproductive health. A recent government commissioned survey, the largest of its kind, revealed that more than a quarter of women in England are living with a serious reproductive condition. And when you dig deeper, the inequalities for women of colour are stark in comparison to their white counterparts. Black women are 69% more likely to face these conditions, with fibroids affecting nearly 1 in 5 Black women, and South Asian women reporting higher rates of conditions such as PCOS and endometriosis. But behind these statistics are real lives disrupted, from education cut short, careers derailed, relationships strained, and fertility impacted. Too many women are still being told their pain is normal. That's why today's panel is so important and personal to me, because I'm joined by 4 phenomenal women who are not only advocating for change, but also sharing their lived experiences so we can shine a light on the realities of reproductive health and the changes we urgently need to see. Joining me today are GP educator, lecturer, speaker, and a respected health content creator, Dr. Aziza.
Hi.
Welcome. Hi. Biomedical scientist, Jasbir Jutla. Hello. Friend to the show, TEDx speaker and founder of Sisters and the Maternity Justice, Neelam Shergill. Hello. And last but never least, healthcare graduate, experienced doula, mentor, teacher, and founder and CEO of Black Mama's Birth Village, Lorna Phillip.
Hello.
Welcome.
Thank you.
Hello, ladies.
Hi.
Hello. Thank you so much for joining me. But I really want to kick off and jump into this because we've got a lot to talk about and discuss by starting to look at the facts. So I'm going to come to you first, Aziza, because as I mentioned, this is a very underfunded, under-researched issue, but the data is staggering, particularly for women of colour. So I'd really like your perspective about what the current research and statistics are telling us about reproductive health in the UK today.
Ooh, loaded, loaded. Where do I even start? All right. I mean, the realities are that we make up 51% of the population. And sadly, when we think about research, and this is a fact, the funding in research is around 1 to 2% for women's health, right? The rest of the research is not specific or exclusive to women's health. And this is when we remove cancer. 1% for over 51% of the population, which is insanity. So a lot of the times when we think about a lot of the conditions that you mentioned, PCOS, fibroids, adenomyosis, endometriosis, PMDD, a lot of these conditions, we still do not know why they happen. And because we do not know why they happen, guess what? For a lot of them, we don't have definitive cures. Or if there is a cure, for instance, if we talk about fibroids where you're having non-cancerous growths in and around the womb, the only cure is removing the womb. Removing a whole organ, which is, you know, a vital part of our anatomy, and it then renders the individual infertile. So this is the stance that we're currently at. And as you mentioned, as soon as you add intersectionality, so you add race and ethnicity, or you add neurodiversity, and then you look at disability, LGBTQ, as soon as you add that, the disparity widens even further. So there's a lot of work that needs to be done. There's not enough research in women's health, but then as soon as you add those intersectionalities, there's just very, very minimal research within those communities.
Could you kind of break down to us what that actually looks like in everyday life for some of the women or the females coming through your clinic?
Yeah, so I see this a lot, and particularly within the marginalized communities, as we've spoken about, is we've normalized the symptoms that are associated with these conditions, and that can include heavy bleeding. When we talk about heavy bleeding, a lot of women don't even realize what that constitutes as, and that's if you're bleeding through your clothes, if you're having to double up on period products, if you are constantly needing to put towels on your beds because you're worried that you know that you're going to soak through your bed sheet, if you are constantly feeling really, really lethargic. So if you're losing too much blood, you become anemic, and then you get symptoms associated with anemia. So that's headaches, dizziness, shortness of breath, chest pain. Those are all symptoms of anemia, and it means that you're probably bleeding too much. As well as the heavy bleeding, think about pain. We've normalized well, not we, but society has normalized women's pain. It's almost like it's a plight that we have to deal with. Oh, it's a painful period. Get on with it. Pull your socks up. It's just a period. Everyone has to deal with it. No, you don't have to deal with it. If your periods are so bad that it's stopping you from living, that you cannot do your day-to-day activity, you can't go to work or school. And we're seeing teenagers who are experiencing this, but because it's been normalized for so long, it's passed down intergenerationally. Like, well, you know, my mom went through it and her grandmother went through it, and we've normalized these things. So that's what I'm seeing in clinic. When they have come forward, it's almost like, oh, I'm so sorry, I don't want to bother you, or you know, it's one of those things, or it's a by the way symptom. And I've even seen that where a mom would come with her teenage daughter, and her daughter would be like, oh, it's just a period. That phrase I hear too much of. But it also goes the other way, where sadly I have seen patients, and this is family members, and obviously because I work in this space, I've heard stories where women do come forward about their symptoms, and sadly they've been dismissed, sadly, by doctors. Because as well as the fact that there's little awareness, there is medical misogyny, and we know that exists. There was a report that came out last year through the Royal College of Obs and Gynae where we've spoken about the realities that medical misogyny is real, and it's rife, it's a problem, and we need to change that.
It's an interesting point that you've talked about there, medical misogyny, because I feel in my experience, a lot of the doctors I saw were female, and the dismissal came from women. You know, just to add my context to this, I was diagnosed with fibroids in 2013. At the end of 2023, I had a open myomectomy to remove very large fibroids. And you talk about the misogyny, but does that necessarily have to come from men?
No,
because it seems to go through the whole.
I said medical misogyny. I didn't say male misogyny or male
and I just wanted
misogyny.
to pull that out.
No, it doesn't have to. We've internalized it as ourselves as well, because like I say, within communities, and I've heard it, I've seen it. You know, the daughter is complaining of severe, painful periods, and then her own mom will say, we've all had this. Why are you complaining? Deal with it. Again, it's internalized, and it's just the society that we live in. We live in a patriarchal world, whether or not we choose to accept it. It's a reality, and it's almost like, it's so sad. We're in 2025, and it almost feels like we are literally going backwards. We progress so much, and we've taken 10 steps forwards and 50 steps back in the last few years. So there's a lot that needs to change.
I think you've touched on something that most of us share, which is lived experience, because the numbers are only really telling part of the story, because behind them are real people. I mean, Jazz, could you share a little bit about your own experience and the experiences you've had?
Yeah, so I started my periods when I was 11, and from day one I was in excruciating pain. I was having to take time off school. I was passing out at school, like blacking out. So definitely days 2 and 3 of my cycle, worst ever, and bleeding really heavily. But my mum, because she had fibroids, it was like the norm. So like as Aziza said, you know, you just kind of say, oh well, yeah, mum had it, and it'd be like, have some painkillers, have a hot water bottle, and just rest. And then I remember going to school and my friend saying, my period lasts for 3 days and I don't bleed. And I looked at her and I went, well, you're not normal. Because for me, normal was what I was going through and what my mum was going through. And it progressively got worse over the years. And I think I'd started my master's, so this will have been around about 2001. And I put it down to the fact that I was stressed. I was still working full time, so I was working in the lab. I was doing on-call, and I was doing a day release master's as well. And I was like, I'm doing too much. I was also going to the gym. But it just got really, really bad, and I was losing really large clots. Right. And my mum said to me, she goes, I think you've got fibroids. And at that time I was, 23? Yeah. And I was, I don't think so, Mum. And I went to the doctor and I said to her, look, I'm bleeding really heavily. I'm soiling my clothes. I'm losing massive clots. I think I've got fibroids. And she just looked at me, and it was a woman, like Ziza said, it was a woman. So you trust them. You think, yeah, they're going to look out for me. It's a woman, it's not a man. And she looked at me and she goes, every woman thinks she bleeds, but in reality, it's only an egg cup full. And I just looked at her and I said, how big is this egg cup? Because I am wearing 3 or 4 pairs of pants. I am wearing about 3 or 4 pads. I'm wearing cycling shorts underneath my clothes and I'm bleeding through my clothes, and I'm losing huge clots. They're like Jaffa-sized clots. They're not, they're not like little clots. And she just looked at me. She goes, "No, you're far too young to have fibroids." And she fobbed me off. And here, have some tranexamic acid. Off you go. And we'll put you on the pill. And if you take it back to back, you won't bleed. Well, yeah, I bled constantly then. And it was like, and she just went no. And then it was one day when I actually went to work, and I parked outside, and I literally walked inside, and literally as we walked in through the door, the toilets were on the right hand side. I walked in. As I got out of the car, I just felt this huge gush of warm blood, and it was just trickling down my legs. And I just thought, oh my gosh. I just ran inside, and luckily there was nobody in the car park. I ran inside, and I just sat on the toilet, and I was completely soaked to my knees in blood. And I just sat in the toilet and I cried. I just sat there crying. I cried for a good 10 minutes. I was like, what the hell is happening to my body? And I was in there, and I phoned my manager who was in the lab, and she's like, where are you, Jas? I can see your car in the car park. Where are you? I was like, I'm in the toilet. She goes, what are you doing in the toilet? I said, can you please just come to the toilet? And I'm sobbing. And she came and she looked at me. She goes, oh my gosh. She goes, have you got any spare clothes? Well, obviously I didn't. And then she went and got me a disposable lab coat. She goes, go home. And I had to wrap this lab coat around me. I had to put, I had carrier bags in the car. I had to put carrier bags on the seat. And I got in the car and I drove home. And my sister was home from university, my younger sister. And I opened the door, and she just looked at me and she went, what are you doing home? She looked at my clothes. She goes, get in the shower. She goes, I'm phoning the doctors. You get in the shower, you get changed, I'm taking you to the doctors. And I went to the doctors, and it was a different doctor, but another female doctor. And I explained everything. And for the first time, because I'd been back and forth to the doctors, here, take this pill, take this, take that. And she looked at me and she goes, right, we need to take some bloods, and I'm referring you to the gynecologist right now. And when my blood results came back, so normal hemoglobin levels are between 12 and 14, mine was 7.6, which explained the tiredness, explained everything. I was sent for her hysteroscopy. And I remember my mum coming in with me, and so this is literally 2 years after I first went to the doctor, so this is 2003, and I went in, and they keep you awake for the hysteroscopy so I could see it on the screen. And as she's putting the probe in, she's going, oh, here's a fibroid. There's 3 different types of fibroids. 4, yeah. I had all of them. Wow. I was literally riddled with fibroids. My uterus was the size that it should be if I was 5 months pregnant. Wow. That's how bad it was. Nobody knows your body better than you as an individual. You are literally the expert of your body. You are literally the CEO of your body. If something doesn't feel right, it means that it's not. It's not. Couple things to pick up. Just because something is common, or if it runs in the family, it doesn't mean that it's normal. You can have things that are common, like heavy periods. And by the way, passing clots bigger than the size of a 10p coin, or bigger than this,
that's not normal.
Yeah.
So
Yeah.
yeah, and also remembering that we obviously should know what our normal is, but just because it's normal for us doesn't mean that it's normal in general, right? So you had really heavy painful periods, and then really quickly, there are, yes, I don't want any male doctors to think, oh my God, they're just bashing the men. No, there are some really, really great male doctors out there, but the reality is that we have a lot of patients who've had this experience from both male and female doctors, and we need to do better as doctors. But also, if you see a doctor and you feel like you're being dismissed, and actually we know that this is the case, women in the UK, when they did the call for evidence, the Department of Health, they found that over 80% of women said they didn't feel as though their healthcare professionals listened to them. 80%. So that's a big proportion of women, and it's probably even worse for women of color. So if you see a doctor and you feel like you're hitting a brick wall, please seek a second, a third, fourth opinion. Just do not give up, and know that there are some GPs who have the expertise in women's health. So for instance, I am a GP with a specialist interest in women's health. So I've done diplomas, I've done extra training. Not all GPs will have that, and that then has an influence. So if you're going to see a doctor, it's maybe worth going onto the website and seeing what letters are after their names, or specifically asking for the women's health specialist in the GP surgery, so that you can get that additional optimal care. But,
I think what we're talking about really is getting to a place where we as women can advocate for ourselves. And I know, I'm looking at you because that's definitely something you did. And as you mentioned, Aziza, if you feel dismissed, you should look for someone new. And I think that's something you talked about before. I mean, obviously, Neelam, you've been on the show before, but you really had to fight to make yourself heard, really, because you were constantly dismissed, weren't you?
For a long time. So I think I had a couple of other issues. So I was a student in Birmingham, and typically when you're a student, you don't live in your home for longer than a year, because you move to the next one and you move to the next place, because your student contracts are like about 11 months at a time. So I had a different GP all the time. I had physically at a different place, or under a physically different GP. So you're talking about the days where we weren't as digitalized. I actually remember having, it was like a pale yellow pack with all your medical notes. That's what I remember people having of mine. But then you have to be very good at being your own historian of your health. And when you're not well, you're not a great historian. Unless you are writing everything down from the beginning. Bear in mind, I didn't do that because I didn't know I had to do that. So I had a couple of additional things, like physically moving around. I never had the same GP. So I was always having to retell my story to somebody. I never got my story right every single time. And when I remember a specific one where one of the GPs that I'd gone to see in a new surgery when I just moved to Selly Oak, and they'd asked me why I'd had certain referrals, and I was like, I just don't know anymore. I'm just not okay. I don't feel well. And I think things got a bit more serious for me is when I blacked out in the office when I used to work in a law firm. That's when things got taken seriously, because the law firm obviously had to call an ambulance. And it was also really embarrassing for me because I was working in a good law firm. This was my career. This is everything I ever wanted. And then suddenly in front of everybody, and it was like something that I knew everybody was also talking about. So I was embarrassed. So I didn't want to share what was happening with me, but then I had to suddenly disclose to my workplace that I'm just not well and this is happening to me. And but I also had no name for what was going on with me because I hadn't got a formal diagnosis. So all I could say to them is, I'm bleeding a lot and it hurts. And that isn't taken seriously in a workplace context, because I just sound like I can't handle a period, and that was how it was taken.
I'm going to come back to you again in a moment, Neelam, because I think that's really poignant what you said. But Lorna, I just want to touch a little bit on your own experience as well, because you struggled with fibroids as well, haven't you?
I did, yes. A few years ago. I've got to say, I know that I'm the oldest one amongst you. And as we
would never believe that.
I know you wouldn't, but I am. Kind of hearing you all talk about kind of periods and reproductive health, I'm just sitting here listening to your experiences, but thinking back to the time when I started my period, way back when, 13-year-old, and the whole mystery and the whole taboo and the whole shame of starting your periods back then when your mom gave you this big fat Dr. White's pad that had no kind of sticky back to it. It had like a belt. Okay,
wow.
so it had loops at either end, and it had a belt that you loop through and tie around your waist, and you've got this big brick between your legs, or it has a little pin, so you had to pin the loop at the front of your pants or one at the back, and that was put into a little plain bag for you to go to school, so you could obviously change whilst you're at school, but it was very much a very private thing that we never, ever spoke about. I even remember my own mom getting told off by my dad for leaving a box of Tampax out on the bathroom windowsill for us all to see as kids. I had heavy periods for forever, and I never ever went to my doctor because back then it wasn't like you just didn't go to the doctor for your period. You know, I was soaking through my clothes. I could never have sat on a sofa like this. I'd have been so afraid of bleeding through my clothes. I had all the pads, all the everything on, and I could never sit on a sofa like this. But it was after I'd had my children, and I just could not continue, like, you know, the tiredness, the feeling faint, the headaches, the dizziness. So I went to my GP, and I was eventually diagnosed with fibroids. And I had a number of options, but I actually chose to have hysterectomy in the end. I really struggled with how my friends and family dealt with the news of me choosing hysterectomy. They were saying that, but that's your womanhood, that's your femininity. How could you have your womb removed? But I'd finished having my family, and I was more than happy to go through the surgery, and it's changed my life totally.
You said you had the choice of a hysterectomy, but I feel like so many women I've spoken to in hindsight have, especially seeing how information is now, realising that they didn't have that choice, that they were kind of advised to do this. When I'd started to be a bit more vocal in my family about this is what I'm going through, this is what I'm experiencing, a lot of the females in my family came out and said, yeah, I've had that. That's why I had the hysterectomy. And then when I've talked to them about the procedures that I was going to go through, they were like, that's an option. I'd, never heard of that, etc. And as you mentioned earlier, it's the removal of a vital organ. But Jazz, that's really an experience you've just been through also, haven't you? But were you given the option also?
I'd had a previous myomectomy, so I had endometriosis as well, and I had lesions around my right ovary, so I'd had most of my right ovary removed. But then obviously things got worse, and then I was bleeding. So I'd been bleeding for 6 months constantly. The doctor had put me on the pill. I was taking it, and she goes, just persevere with it. It will stop eventually. I was like, it's not stopping. I was wearing incontinence pads because that was the only thing. I had a large fibroid sitting at the top of my cervix, so I couldn't use tampons, and it was too painful to use tampons. So I was wearing incontinence pads, and then I just said, enough's enough now. I went back, and then I saw a different specialist, Mrs. Jane. She was great. She actually listened to me, and she said, okay, but the waiting list is very long. And I'd previously been given the Prostap injection, which is a injection which kind of is a chemical menopause. It puts your body into menopause, but that was the only thing that I knew would stop my periods. And I begged her, but I was never told this initially when I had it, that it actually causes bone thinning, so they can only give you a limited amount of injections. She told me the waiting list was 6 to 8 months for a hysterectomy, and she said, I can give you 3 injections. And I was like, but then I'm going to start bleeding again. And I said, can you give me any more? She goes, no, I can't, because it causes bone thinning. And then I was like, well, can I go privately? I was so desperate. I was like, I will go private. And I said, can you tell me how much it's going to cost? And she looked at me, she goes, you don't need to go privately. We will get you sorted. So I was put on the list in November last year. I think end of January, because mid-January, I had a phone call from her secretary, and she said, and I misheard because I was on a Teams call at the time, and I misheard her, and I was like, why am I coming to you for an injection? I'm going to my GP's. I just need your authorization. And she goes, no, we're booking you in for a hysterectomy. So I had 2 weeks, 2 weeks notice, and I was like, oh my gosh. And then it was like, oh, then I went into overdrive. I phoned my manager. I was like, and she goes, look, Jess, you need to get yourself sorted. She knew how much I was suffering. And my manager's been great. You know, she would be like, you know, if you need to take time out from your day and go have a rest, you look after yourself.
Aziza, listening to Jazz's experience in terms of and the options being provided, what are some of the similarities you see of some of the women coming in when that is put on the table, the hysterectomy? What are some of the emotions that they are experiencing, much like Jazz, I imagine?
Yeah, I mean, I'm listening to Jazz and I'm just thinking that this condition is classed as benign, right? But a lot of these conditions are classed as benign because they're not cancer. But that is such a troublesome word. And that is exactly why there's so many women who are having to wait months, years. Like the waiting list right now is absolutely ridiculous. I think it came out just the other day that 54% of women aged between, I believe, 18 and 64 are on the waiting list. 54%. That is a lot of people. We have over 750,000 people waiting for these routine procedures because these conditions are seen as benign. But nothing that you just described sounds benign. It sounds life-threatening, and it sounds like it stops people from living, right?
I've seen the word disease being used a lot recently. Is that a classification that it's starting to be recognised?
So I think that there's definitely a push at the moment to try and obliterate that term because it is very, very problematic. So first of all, we need to change the language around certain aspects of women's health. And this is, again, what is attributing to many who are suffering, just as you have. But I'm really glad that you had the options and that you ended up having a great doctor, because again, it does help if you have a great doctor. In order for me to describe treatment, I do have this. So I know that we've spoken about the condition. I just really quickly, because you mentioned that there were 4 different types of fibroids. So when we talk about fibroids, it's when you have non-cancerous growth in and around the womb. So the 4 different types include the intramural. So that's where it's bang on in the middle of the muscle. You can have submucosal. So the womb is made up of 3 layers. So the submucosal is the inner layer. And then in between where the muscle is the muscular layer. And then you have the subserosal, which is the outer layer. So submucosal is where the fibroid is pushing against the inner layer. So it's pushing against the womb lining. And that's the one that causes a lot of that heavy bleeding. Which is what you were describing. And then you can have it in the cervix. And then you can have subserosal where it's pushing outwards onto the outer wall of the womb. And then you can have the pedunculated one, which is where it's basically hanging like a stalk, and it could be hanging inside or it could be hanging on the outside. And depending on the type of fibroids you have, where they're located, the size of them, and obviously the symptoms that you have. So I do need to stress, I have a fibroid as well. And actually I'm one of the around 50% who doesn't really have symptoms with it. I'm very fortunate that mine was incidentally found. It only impacted me during pregnancy. So it affected the size and the growth of my children. But apart from that, I was pretty asymptomatic. So you can be one of those people as well.
I was one of those people.
You're one of those
I
people.
didn't even know I had fibroids in my pregnancy.
Exactly.
But it didn't really affect, because I've got endo and PCOS anyway, so I was a bit like...
It's like, one more thing. That's
but no one
important
told
to say.
me, interestingly. I read it in my Badger notes.
Oh, really?
Yeah, I read it in my notes. So I didn't actually know. But I also didn't know I had a postpartum hemorrhage either until I read it in my notes. No one told me.
So you found out you had fibroid and the hemorrhage in
my notes.
In your pregnancy?
In my notes, yeah.
Wow.
Aziza, I was going to ask a question. Because I don't actually know anything, because it just says fibroid. So I've never even questioned it. Is there one worse than the other? Or is it purely on location?
Honestly, it depends on the individual. Okay, so intramural, if it's not that big, so I have an intramural one, and that's the most common one, it can be okay. So the most common type of fibroid is the intramural one, which is where it's bang on in the middle of the muscle. And if it's not that big, then it won't really cause that much symptoms. So maybe that's the one you have, I don't know, but it does depend on the individual. Usually if it's submucosal, so it's pushing against the womb lining, that really does cause heavy bleeding for a lot of women. And also you need to remember that the womb really, when it's normal and you're not on your period, it's really tiny. It's such a tiny organ that can grow into basically the size of a watermelon when you're pregnant. But as can the fibroids. So they feed off the hormone estrogen, and that's how one of the treatment works. And I'll talk about that in a second. But Yeah, so those are the different types of fibroids. And when we think about the treatment options, we always start with medication first, which is what you're offered, because as a GP, that's what we can offer. And I do want to stress that just because we don't know what's going on doesn't mean we can't give you treatment whilst we're waiting for the investigations. And please do ask for the investigations. So that includes bloods, doing scans. So it could be an ultrasound scan. Sometimes we need to do an MRI scan, and sometimes you need to go in for surgery where they do keyhole surgery to have a look inside to make sure that we're not missing anything. Or they may do what's called a hysteroscopy. That's where they put a tube with a camera in the top through the vagina in through to the cervix to have a look inside.
What's going on?
And that's how they usually see submucosal fibroids. So treatments include medications, painkillers. You mentioned tranexamic acid, so that's a medication that helps to lessen the heaviness of the bleeding. There's mefenamic acid, which is a strong painkiller as well. There are the hormonal pills, which for some women really helps, because again, how the hormonal contraceptives work is they basically just keep the level of your hormones lowish, and in that way the fibroid isn't feeding off the estrogen, so hopefully that helps to alleviate the symptoms, and it should stop you from having periods, but it's not always the case for everyone, as you mentioned. And then there's the other hormonal treatment where it's called GnRH antagonist or agonist. So how they work is essentially, so GnRH stands for gonadotropin releasing hormone, okay? And that's often released from one of the bits of the brain. I don't want to go into too much depth, but they actually have to do with the release of estrogen. Through that, that's how it stimulates the release of estrogen. Now, if we reduce the amount of the GnRH, if we reduce it, then that has an impact on the amount of estrogen that's released,
going into,
which then will have an impact on the fibroid. So that's how that works. When we are in menopause, our estrogen levels drop because the majority of our estrogen is released from our ovaries. Yes, we do have a little amount that's come out from the fat cells as well as our adrenal glands, which sits above the kidneys. But it's reduced significantly, and that's what those hormonal medications do. And that's why, again, why some women, when they've gone through menopause completely, they notice that their fibroid symptoms have eased. You know, because it feeds up. And then if we go down the surgery route, they may do a hysteroscopy where they go in through there and they may remove the fibroid through that technique. They may do an abdominal operation where they remove, so it's called myomectomy. Myo meaning muscle, oma meaning tumor. So myoma is actually fibroid. Ectomy just means remove. So they may remove myomectomy. They remove they remove the fibroid. Or there are other treatments where it's not removing the fibroid per se. There's a newer one that's called Sonata, where they basically burn the fibroid essentially.
They've got a radiotherapy
yes,
one
radio
now as well.
frequency, exactly. And then there's another one where it's called artery embolization. So they block the blood supply to the fibroid, which then shrinks the fibroid, which can work for some. There's ablation where they literally burn the womb lining to stop it from thickening, which for some women, again, it's almost the same as having a hysterectomy because they're not bleeding anymore. And then hysterectomy, hyster meaning womb, ectomy meaning removal, is where they remove the whole womb. So those are the different treatment options that are there. There are probably a couple more that I haven't mentioned, but essentially what we're trying to do is help alleviate the symptoms. That's what we're looking to do. We want to allow the woman to go on to have her life back. And sometimes you don't need to have a hysterectomy. You can have these other options which can help. And I have found that actually there are loads of Black women who are offered hysterectomy.
Right.
Thank you.
Thank you.
Yes.
We've come to...
And that needs to change.
Yes.
And that's why I'm constantly sharing that there are other options. If they say hysterectomy, go and ask, what about this or that? And also seek a second opinion, because it doesn't, you don't have to have it if you don't want to have it.
Why is that happening?
So I was lucky enough to have the options. In fact, they did try the ablation first and it wasn't possible because of the fibroids. But my personal theory is this whole wanting to control the fertility of Black and brown people. Okay, for example, I've had South Asian clients, doula clients, who may have had 4 children, 5 children. There's this kind of no more for you now,
Yeah.
miss. You know, we don't
You've
want to have
had
it
enough.
anymore. You might want to consider this and that, and long-term contraception, and they want to go on and have more children. It's kind of frowned upon.
Yeah.
So I think there is an element of control of our fertility and our reproductive system that goes on, and that's why I think that they are offering these quite radical surgeries, or at least kind of long-term contraception options, in order just to kind of keep it under control.
I mean, it's almost a running joke, and I'm sure you've heard this, right? That like Black and brown families have big families, and you have like several brothers and sisters. Like it's almost a joke. So I do agree with your point, because you hear people joke about it.
I think it's that, but I also think as a doctor who's been told, I'm actually sharing a personal story. I had noticed that my periods had gotten heavier. I know I have fibroids, and I was like, oh, is it to do with my fibroids? Spoke to the GP over the phone. I didn't quantify how heavy my periods had become or anything like that. And she immediately said, well, why don't you have a hysterectomy? And I remember no, nothing. And I remember being really surprised, because I thought, well, how can you offer that as and I had to say that to her. And she's like, I mean, you've had 2 children. Have you completed your family? I was like, at that point, I'm in my mid-30s. I don't know if I've completed my family, but also I'm a doctor. So I am aware that there are other options. There are other steps we can take before we get there. And I don't know if maybe sometimes it could, I mean, obviously I can't speak for her, but it could just be, well, that is an option. You won't need to ever come back again. Take it. You know, and at least you're giving.
So you think it's maybe not related
option?
to race as much, or?
I can't say that for sure, but what I do know is that what I hear a lot, what I've seen, and what the statistics have shown is a lot of Black women have had their womb removed.
Absolutely. And I'm not too sure. We talked about this off camera. The statistics always say Black women are X% more likely, blah, blah. And I can't get to the I think we talked about that, the intersectionalities of the communities, like what does it mean for the South Asian women, for example. So I'm not sure at the rates per se of hysterectomies within the South Asian community, but from the stories I've heard, it's the same conversation, like, come in, this is your option. And, you know, you mentioned about us having big families. My grandma is one of like 12 or something. My parents are one of 9. I'm one of 6, trying to have one of 1. Like, I want to kind of delve into a little bit of the causes before we get to the impact on the fertility, because you talked a lot about the estrogen, you know, being, I suppose it's not a healthy environment for the womb if there's too much process. I'm not sure. What's happening here? Why is it affecting Black and brown women at such a high rate?
That's a really great question. And guess what?
What is going on?
We still don't know, because as well as the fact that we don't have as much research in general, as I mentioned, we don't really have it when it comes to South Asian and Black women. And part of the reason is to do with trust. There are not many Black women who want to come forward when it comes to certain aspects of research based on the past experiences. We have been used and abused in the past. And I mean, and often we say, oh, this is historic. It's not that historic. Some of these things happened only like less than 50 years ago. And they're still happening now. So there's a lot of distrust, but also often the people who are doing the research don't look like us. So you're not going to believe that. And often, yes, absolutely, they will have the best intention to heart. But it's important that we are representative and we are inclusive in who is forward facing as well. And it's not just, sometimes you often feel like, is this just tokenism or is this real? Do they actually really care? But this is part of why, again, when we think about the research that's out there, there's not enough that includes us so that we can understand what's going on. And when the research is done, it's not that representative. So maybe the treatment is good. So one thing that I'll mention is, for instance, breast cancer. Recently, there's been some studies that have found that actually some of the treatment that they're giving to even Black women don't work for Black women, because the way that breast cancer presents with us is very different. So that's why they often say, oh, we're treatment resistant. No, we're not necessarily treatment resistant. The treatment wasn't made for us because the treatment wasn't researched through us.
Yeah.
So there's a lot of work that needs to be done for there to be more trust, and change happens at the speed of trust.
And I just wanted to come over here a bit, actually, because we've onto the whole research thing, because I know that you, Neelam, have...
I always try and pull you into things where I can.
Pull me into this stuff, which I'm really enjoying. Thank you.
If anyone has watched the show and seen Neelam's episode, then they'll know that you talked very extensively about your experience with endometriosis. So I would advise anyone to go back and watch that. But in terms of the research and what's taking place, getting it on the table, I know that hasn't been the easiest journey. And obviously, Lorna, you're involved in that now too. Can you tell us about what's happening?
So something that we have an offering at Sisters is that we can support with NIHR applications.
NIHR?
NIHR stands for
the National Institute of Health Research.
That's the one. That's why I look straight at you, because acronyms are not the one for me. What tends to happen is you'll get a research call that gives you 2 weeks of a deadline to get a very big research application in that has to cover all the community. So what tends to happen is researchers who have been doing this work for years will just call upon their friends to get this bid in. And what we've started doing is pushing back, because we will get a last minute request to say there's no PPI lead. So a PPI lead is a patient and public involvement lead. To give you an example, this week alone, I had a conversation with, I won't say the university, who wanted to jump on a really quick call with me. It's always 5 minutes, apparently. And they had done a preliminary survey around anti-coags and heavy menstrual bleeding and a research bid they want to do, but they had no people of colour to inform what their research is. But Neelam, can you just get us different people from different communities? But we have no budget. And that email and that 5 minute conversation I have 3 or 4 times a week. I get that email quite often at Sisters, and it is not that I don't want to help people. I physically do not have the energy to do this work unpaid anymore. So what we have been doing is shouting about the paid work and shouting about our work, and there's stuff that I've brought Lorna into, like heavy postpartum hemorrhage study, which was a clinical trial, which we informed on and supported with in Birmingham. And I think we really went to town with even their ethics and everything, because they had no people of colour until Sisters got involved, and they had no trans people, no non-binary people, but they were trying to talk on behalf of all of us, but they weren't any of us involved in the research. And so that's really led to us changing how we do research. So there's a research that we've just put out there around disability and abortions, and that's not an area that anyone's ever covered before. And we had a very small pot of funding, which we just put into the community. We didn't pay ourselves. And that's not to be a martyr to the space. That just shows the amount of money that goes into community-led research and research that is about the community for the community. But NIHR funding, you're talking about millions. You're not talking about little money, you're talking about millions. And so where we reframe our work at Sisters is not just reproductive health anyway, we call it menstrual maternal justice, because we're coming from a place of justice now, reparations. We're looking back at all the years of how we were subjugated, our body autonomy was taken from us, and we're seeking justice for that now. And so our work is framed around decolonization, but collective liberation. And the reason we term it like that, this is not my journey, this is not just yours, it's a collective experience that we are having as marginalised folks, not just black and brown people, but all levels of marginalisation, including class and gender. Class is a really big thing in this conversation because a lot of people don't know how to advocate with their GP. That's me included. It's funny, I can have this conversation right now with you, but I promise you, put me in front of a GP, I'm a really different person. I'm very nervous and anxiety riddled. And that's why I think research can support with all of this, because I think these things need to be explored in more depth, because without having our voices at the table from the beginning, the research will never be about us. It will never fit us. And when it's put into policy, it's never going to filter through to the communities that we're working with. So then we continuously be stuck in a vicious cycle almost. And so The other thing to mention with research, it takes on average 8 years to get that research into policy in the first place. So the stuff that we've worked on for what, nearly 2 years now, that's going to be another 8 years before that's going to go in anywhere and make a difference. So then there's that expectation that you're asking people to be part of research, and they get really happy. And I get really happy and guess I've shared my story. This is going to go in the BMJ, which is the British Medical Journal, therefore it's going to make a difference tomorrow, but it's not. It's going to take years. And I think that also is a reality that's hard to, it's a bitter pill to swallow, that it's not going to happen overnight. I don't understand why it's not going to happen overnight. I don't know why someone can't just be like, this is a stark lot of research, let's do something with it.
That's a really good point, because I mean, I don't know, depending on what side of the fence you sit on, but if you think about COVID, it came in near enough overnight. Then we had a jab for it the next day. Not enough research for it. You know, whether you took it or not was down to yourselves. But we managed to get something moved into the medical space almost, you know, instantly, radically. But I feel that's because a lot of the things that particular issue was causing were impacting on economy, impacting on some of the financial status of the global economy. But does that provide a case for us tying these reproductive issues to things like financial money? Because it feels like it always comes back to that.
It does, and that's the biggest driving force. So the McKinsey report, I think last year they came out to, I don't remember the exact figure, but essentially what they're saying is that if you improve women's health, you would make trillions, you know, bring trillions into the economy. And all of a sudden it's like, ooh, maybe we should focus on something that affects 51% of the population. So no, absolutely, money has a lot to do with it. And sometimes, and I'll be honest, obviously I've been very fortunate to go to Parliament and support different reports and talk on matters and represent, you know, often people who are unseen, unheard. But one thing that I've said a lot of late is, you know, that we've had a lot of reports, we've had a lot of this research, we've heard all of the stats, 5 times more, 2 times more, 3 times more, 6 times more. What's the action?
Where's the
what are we doing next? What are we going to put into actionable change? And sometimes and I think, yes, it's so important that we are included in the research and our voices are there. But one thing that I feel people forget to take into consideration is the fact that this is psychologically exhausting, and it definitely has an impact on mental health to constantly reiterate the stats that actually pertains to you as a human being
and our trauma
and our trauma. Having to relive that trauma, I feel people forget, and sometimes it does feel like, are we glamorizing this problem? Are we admiring it more than we're actually putting things in place to make change? But as you say, we're all on the sofa and we're all here to advocate and make change. We just keep it pushing and hope for the best, and hopefully our children, because I don't know if it's going to come in our time, but at least our children and grandchildren can reap the benefits of the hard
we're
work.
a lot more vocal than previous generations. Definitely. But I really want to bring you in here, Lorna, because and also relate back to probably most of our experiences here, fertility. Because as a doula, I know that you have so many women coming through your doors, but of the percentages, how many do you see that are struggling with fertility issues because of some of these reproductive challenges we're talking about?
Right, I would say not so much as a doula, but I'm also a mesantherapist. So mesantherapy is I guess it's a kind of a natural approach to womb health or reproductive health. So we see people with PCOS, endometriosis, menopausal symptoms, the kind of whole raft of things. And it's about helping people to manage those symptoms and help to alleviate some of the symptoms of those conditions. And definitely, I will say the majority of the people who come to see me are actually my Muslim women. And not that many African Caribbean women. I think it's because we don't know about it so much. But definitely there's a big thing, an issue about our fertility. I've had women who said, I've been trying for 7 years. And I said, well, you know, have you been to your GP to kind of say, you know, what's going on here and get some tests done. and they've been told, well, actually, there's nothing wrong with me. There's unexplained. And so they're now like reaching out, thinking, what can I do? Where can I go to? And before they go down the assisted, pregnancy with IVF and that kind of thing, they want to come and try something that's kind of more natural and holistic. So yeah, there is a problem. What's causing it? I would love to know, but there's definitely an issue with fertility. Because
I would love to know myself in terms of why we're so much more prone to have these particular issues. But just to bring some light to what these issues do to our real lives, I mean, I've had conversations with both yourself, Neelam, and yourself, Jas, who struggled with fertility, much like myself, because of the issues that we're challenged with. But your stories have like a wonderful light at the end of the tunnel, because you've both been able to have children, which is fantastic. But just talking about the experience of going through the process of wanting a child and knowing that your body is kind of blocking that blessing in some way. Probably not the best term to use, but you're challenged by that. Can you talk to me about some of the emotional distress, I suppose, that caused, and how you have managed to get through it?
I think even to you, I told you for a long time I didn't want children, and it wasn't because I didn't want children. I just didn't think I could, so I didn't want to set myself up to fail. And I'm sorry if I get emotional, because it's still raw. Even though I've got my daughter, it's not been an easy journey. And even the first few months of bonding with her, I was also still grieving my miscarriage and feeling guilty for having her when I hadn't got both of them. So it is a difficult one. And interesting with endo, from the pain aspect, I was told that I would be okay pain-wise. I have not been, as some of you know, my C-section hasn't actually been a smooth journey either. With the healing. And I have to be put back on a waiting list, because they've assumed, because I've had a child, not just from the pain perspective, but I've had a child, therefore everything's okay. Therefore I'm like, I don't need to be on the waiting list for endo anymore. So I actually got taken off when I had Bea, but no one told me that either. It was by chance I had a cervical smear, and I asked them, and she was so good. She looked into it and she was like, oh, you're not on any waiting list. And I was like, but I'm still in pain even though I've had her. Like, it came back, I felt like it came back with a vengeance as well after a couple of months. But I don't know if that was because my C-section was quite bad as well. But the emotional toll generally of doing this work, of also living with this, and the only way I can describe it is you're fighting your body, you're fighting a community who also, as much as we want, we're talking about people that are open to hearing about these conversations. Not everyone is. I have to say, for the South Asian community, is very difficult. I think we're quite a closed community. We want to hear about it, but we don't want to at the same time. So you're fighting a community. You're fighting your head. I know I've struggled with self-harm for many years. Through my last year, I'm still self-harm clean for 7 years now. But I'm not gonna lie, this last year has been tough, and like, thank you.
I will say there's a wedding going on outside. We're not cheering that, but it did feel like the right timing. I think that's birds of glass.
But it has. It's been a tough one this side of the year, because I've been in pain, and there's been times where like my parents have come down to look after. They are quite a lot, and they live in Huddersfield. But I feel like, should I have done this? Should I have had a child when I'm not well? Because I can't look after her all the time. I'm ill sometimes, and Cal has to take over, or my parents come down, and I feel like a horrible, not good enough mum.
Wow.
And then I do this work. And then these stats aren't changing, and then people don't want to fund us, and people want us to do it for free. And it's just stuff on top of stuff on top of stuff on top of stuff. And at what point do people like us as advocates, at what point are we supposed to just be like, we can't do it anymore? And I think for me, that's the hardest thing, is balance everything.
Neelam, your story. So what's really struck me there is that you were taken off the list once you'd had your baby.
Yeah.
So it's almost like we're like vessels, you know. we don't matter in our own rights. You've had your child now, so you don't need any treatment. You're fine. You can just carry on suffering. That's dreadful, isn't it?
So sorry.
It is so bad. Jazz, I know that I can see you nodding your head because I'm imagining you can relate a bit to what Neelam's talked about.
Yeah, they tell you have a baby. Your all your troubles will be
Have a
over.
baby.
Have a baby.
Oh gosh.
Have a baby. Everything will get better. That was what I got told by my first gynecologist, but then at the same time I was told, but you've got endometriosis, you've got stage 3 endometriosis, you've got fibroids, you've got every single type of fibroid possible. You're going to probably need IVF. So which is why I was offered the myomectomy, because I was riddled. My uterus was blocked. So I had the myomectomy, and then there's hope. You're like, it's going to be okay, and then you go on the waiting list for IVF. And then we discovered that it wasn't just me that was affected. My husband also had a low sperm count. He'd had testicular torsion as a child, so he'd had one of his testicles removed. As a result, his sperm count was virtually negligible.
Oh gosh.
So we got told we'd have to have ICSI, which is where they take the sperm and physically inject it into my eggs. So you go through, you're injecting yourself. It's not an easy treatment, and people just say, "Oh, just have IVF. We can't have kids, have IVF." It's not easy. You're injecting yourself every morning. You're then having to go for egg retrieval, where they do it under general anaesthetic at the Women's Hospital in Birmingham, which is where I had my treatment. And then, bang, it worked. So our first treatment worked.
We have some paid
That's
extra.
amazing.
That's great.
So they put two embryos implanted 2 embryos, and I was told I was having twins. And then I started to bleed. So I started to bleed at 9 weeks, and there was there's nothing that they can do. And then I got past that, and then I got told there's still some fibroids inside, they've grown back. So I'd had the myomectomy in January 2008, I'd had my treatment in December of that year. So this was February 2009, and they said some of the fibroids have grown back, you're going to bleed. So yes, you're pregnant, but you're going to bleed. But then at 19 weeks, I unfortunately miscarried. And it was probably the lowest point of my life. The sac around one of my babies the waters had just broken. But then the second baby, her sac was intact. And I was determined that, okay, I've lost one baby. One baby's going to come out. I am not going to lose my second child. But what happens is so I was in labour all night, and it was a similar situation. The doctor that saw me, she spoke with an accent, and this sounds really mean, but I was like, she doesn't know what she's talking about. She can't even speak English properly. She doesn't know. I'm not losing my baby here, because when they scanned me, the hearts were both beating. But she said, "Look, the sac has gone. There is nothing we can do. You're 19 weeks. We're not going to be able to save your baby." So then I was in labour all night, and in the morning, I went to the toilet and I felt something. I was like, "Oh my gosh, I'm not going to have this baby in the toilet." And I called, my husband was with me. I'm from Leeds originally. My parents were in Tunisia. My husband had called my sisters. They were like, "We're coming." And it's like, "No, there's no need for you to come." But I'd had the baby. When she examined me, she goes, "I can see the legs, just push." And the first baby was born. My sisters arrived. In the meantime, my parents had come back from Tunisia. They came straight to the hospital. And then I didn't deliver the placenta. So now what happens when you don't deliver the placenta is it starts to poison your body. But I was adamant that I was not going to let them induce me, because I was going to save my other baby. So this is the morning. By about 5 o'clock in the evening, the placenta had started to properly poison my body. My organs had started to shut down.
Wow.
I was fitting. My temperature was through the roof. My mum had arrived and they said, we need to induce you. I was like, no. And my mum, she grabbed hold of me and she goes, you're my baby and you're gonna die. So you need to let me do this. So I agreed. But then it was like I wanted to punish myself. I refused to have any kind of pain relief. And it wasn't until the following morning that I was exhausted. I had had no sleep. My mum was there, my husband was there, and he's like, just have some pain relief. I was like, no. And I delivered my second twin. But because she was fine, they'd told me her heart would beat for several hours after birth. But there was nothing that they could do. But I couldn't bear to watch her. So and my mum was there, I wasn't in the right frame of mind. And I just let them take her away. So I never actually saw her. And then that was when it was, I think, the day after, later that day, I said, look, I need to see my babies. And that's when they brought them back. But then we had embryos in storage, and it took a good year before I actually felt ready. We had another 5 cycles, so it took us 7 years. And by the end of each cycle, I would beg my husband, go find somebody else, get married to someone else. I can't give you, because like you're right, Neelam, in our community, you get married. When's the baby?
Straight away.
Yeah, when's the baby? When's the baby? I'm also living with an underactive thyroid and my fibroids and my endometriosis. And I was like, let's just look at different options. Somebody mentioned a clinic in India. We were looking into surrogacy, and we were preparing to go. And then in the meantime, the women's hospital were not the best. So then we went to a different clinic, which was based in Aldridge. They've moved, Midland Fertility Services. And when I spoke to the doctor there, he didn't even want to know about when I was starting treatment. He's like, he looked at my records, he goes, you've got all these grade A embryos that they've been implanting into you, but they've never done any tests into seeing why they're not taking. And he goes, we're not going to even think about treatment. He goes, I want to have some tests done on you. And that was the first appointment that I came out of where I actually felt hope. And I didn't cry. I hadn't been crying in that appointment. So I made a doctor's appointment and I took a urine sample because I was being checked for diabetes. And the nurse looked at me and she went, oh, you're here because you think you've got diabetes? I said, yes, but I said, I think I might be pregnant. And I'd done a pregnancy test that morning. She went, well, you haven't got diabetes. I went, okay. She goes, let's do a pregnancy test. I went, okay. And she did this pregnancy test and she just burst into tears. And I went, it's okay, love. It's fine. I'm used to bad news, so it's okay, I know I'm not. And she just looked at me, she went, no, you are. And I was like, but how? I have 1 ovary, I've got fibroids, I've got endometriosis, my husband's got a low sperm count, and how has this happened? And that was it. But then it was like Neelam said, you go through the pregnancy. I was scared to go to the toilet because that was when my waters had broken last time. I went through the whole 9 months terrified that something was going to go wrong. And I think we were all talking about being offered hysterectomies. I've had to fight for my hysterectomy. I don't know whether it's just because I've got 1 child. And they've just kept trying to fob me off. I was like, look, please just give me my life back. Just take it out. I've had enough now. I don't want this anymore. And I had to fight for mine. So I've had the opposite experience where they're trying to kept fobbing me off. I was like, please just take it out.
Lorna, you talked about your practice and what you do. And can you talk us, when we think about pain management and some of the things that the experiences some of the women that are coming to you are having, what are some of the things that you either recommend or can do from I suppose a natural perspective?
So first of all, when they come to us, we see them as a whole. We're not just seeing a kind of a walking room. So we look at, first of all, we ask them to do a health form. And so we look at their kind of lifestyle, what's going on kind of dietary wise, how they're moving their body, how are they handling their stress, what environmental stresses are around them. But the actual therapy itself is actually a manual massage therapy.
Right.
And as children, when a child falls down, we pick them up and we rub their knee, right? Oh, you've bumped your knee, let's make it better. This is what we do with the wound. It's very much a very soothing, gentle massage, mainly for the womb and for around the lower back and around for the legs as well. Just hoping to kind of bring kind of fresh blood to the area and bring about some kind of healing. We never say we cure anything. My aim is to help people manage their symptoms. Right. And it has been shown to lessen pain, for example. If you rub an area of your body, you can bring about some pain relief. We also look at the kind of dietary factors as well. What are you eating? Are you eating lots of fresh veggies, fruits? Are you kind of eating far too much sugar? And so we just have a look at that, and we ask people to kind of tweak their diets and maybe consider some kind of dietary supplements as well, some kind of vitamin supplements. Yeah. But it is a very kind of gentle method of helping you to help yourself, because we give them a thing to do at home, a massage to do at home, and so their kind of condition is in their hands. And for a lot of people, it really helps to reduce the pain.
Yeah, and I love that, because I think you see so much. We talked earlier about the opinions that we're seeing over social media, and there's so much information out there. Do this, do this, do this, but having professionals like yourself coming and speaking about what you're actually doing and how it supports and helps is really, really pivotal, I think, because I think otherwise there's just information going everywhere. And for yourself, Aziza, when you're meeting patients or when you're speaking about this, what are some of the methods and you talked earlier about some of the treatments that can be having, but are there other aspects of treatment that you encourage people to consider, or is it mainly just the medical?
Oh, no, I'm all about holistic. So you're looking at the person as a whole being. And actually, I'm really, really glad that Lorna stressed the point that they do not cure, because that's one thing that a lot of women, unfortunately, are being exploited about. So there's so many desperate women out there who are struggling and suffering with debilitating symptoms. And as I say, a lot of them are waiting for the medical treatment, surgical treatment, and it's taking a long time. So they will go off and look for other alternatives. And where there are promises of cures, you're obviously going to try, and often these cures are very expensive. So I think it's really important that we highlight that fact. And I already stated that sadly with a lot of these conditions, we don't have cures, but we do have treatment options, and that goes from medications, hormonal remedies, to surgery. But I always stress these 5 things to all of my patients, because at the end of the day, if we give you medication or we give you remedies and say that's a plaster over a wound, yet you're still rubbing against the plaster like this, it's not going to heal. The wound would not heal. So you need to ensure lifestyle is so important, okay? Please make sure that you do not smoke at all. And that includes vaping, because vaping is just as bad as smoking, probably worse. Do not smoke. Okay. If you do smoke, please stop. If you don't smoke, don't start. Alcohol, depending on who you talk to. I personally, I don't drink alcohol, and that's a religious reason, but it's also personal. So according to the NHS, you can have 14 units over the course of the week if you want to. So do not binge the 14 units in a couple of days, because some people are like, oh, 14 units, I can have it. No, don't have it over a weekend. You can have it if you want. But some people go as far as to say, actually don't drink alcohol. Make sure that you're having your fruits and your vegetables. I see so many patients with a low folate levels, very low folate level, and it has to do with our diet. A lot of us are not having the fruits and the vegetables, the whole meal, and that is impacting our overall levels. And if you have a low folate level, or even B12, because a lot of those things that we get from our diet, we can't make them. B12, for instance, we need to ensure that we're eating it. Otherwise, we get the pins and needles, the tiredness, the aches and pains, the numbness. If you're getting any of these symptoms, go to your doctor and just see if you could get your levels checked, and make sure that you're eating and you're putting these things into your diet. Make sure that you try your best to maintain a healthy weight where you can. I know it's not easy for everyone, but where you can, please try and do that. And then exercise. We've become so sedentary in these days. And I'm actually going to put my hands up, even as a GP. I don't mobilize enough. I don't walk enough. I don't move enough because I'm sitting at a desk constantly whilst I'm seeing patients. Maybe if I have time, although I don't always, I walk to the bathroom or I'll get up to examine the patient, but that's minimal. We're not moving enough. We're using our cars to go to things that are 5 minutes away, so try and get your exercise. And it doesn't have to be anything strenuous. Often we're like, oh, we need to join the gym. You don't need to join the gym. Go for a walk. Just do 30 minutes, just 5 times a week. So the recommendation according to the NHS is that you do 150 minutes over the course of a week. So it could be just walking. It could be getting something on YouTube and do an exercise video, or just mess about with your kids, like play about, do something, just get moving. That can make such a massive difference. Okay. And then often people ask about supplements. And the truth is supplements are just that. They are supplementary to a healthy lifestyle. So if you're not leading a healthy lifestyle and you're like, oh, well, I'm taking this supplement, that supplement. What? So for some people with some of these conditions, it's actually for everybody, I would say take vitamin D. Okay, just take the recommended. So it's usually 10 micrograms that we recommend. Sometimes people take a 25 micrograms, so that's about 1,000 units daily. And the reason I say that in this country is because we barely get sunlight. So yes, you can usually get vitamin D through the sun.
And a lot of black and brown
people are vitamin D
deficient, aren't we?
Take the vitamin D. But for some people, taking things like the omega-3, magnesium, zinc, that can be helpful. However, I would stress that you see your doctor and have a chat to see whether or not that's something that you need. Because the other thing that can happen is you have too much of it. Yes. You may not need magnesium and you're taking it, and then you're actually it can be quite dangerous if you have too high levels. So it's important that you have the conversation and don't just take the supplements because this person has said that it's worked wonders for them. And maybe it has. But that's for them.
What's on the national agenda at the moment? So I know there's a couple of petitions that are potentially going to be looked at, but can you just speak on that very briefly as what's on the table that the public can actually get behind to make sure that the government are looking at these issues and that we are being able to, address them?
I mean, the Women's Health Strategy was released a couple of years ago, and they had their plans over the course of the next 10 years. And then what happened was the government changed, and that's what made things a little bit different. So now they're looking into newer aspects. But the Women's Health Hub was one thing that they really wanted to push, where essentially it's a community-led unit where you can get your assessments and some minor treatments done. Because actually for some of these things, you don't actually need to go into hospital to get it done. You can get it done within a community. And where it's worked really well, the waiting times have dropped significantly. So I would it's first of all, to anybody who's watching this, share everything that you've learned with at least one person, because I'm always like, you just share it with one person. Doesn't have to go and share everything with everyone, but if you can, one person, and then that one person will share it with another person who'll share it with another person, and we create this ripple effect of knowledge, because knowledge is so key. I often say that health literacy is a determinant of health. What you know will make a difference between life and death, because you don't know what you don't know. So spread everything, all the awareness that you're learning. And then if there are surveys that are out there and you have the capacity and it's online and you have tech literacy, join in and get involved in those surveys. Push back, write to your MPs or the government representative, because they're supposed to represent you, and it's okay for you to do that, and push and keep pushing. Every voice matters. I always ask this question, which I'm sure you guys already know the answer, but what is one V that we all have that we can use to get whatever we want? What's the one V? Do you think it's this?
Our voice.
Your voice, yes. Some people often.
I was going to say my vagina.
I know.
I'm just like, how I get what I want.
Well, that came to mind, but I thought, no, I shan't say that.
Is that what you were asking me?
Not everybody wants that.
It works, isn't it? It just works.
It was voice.
It went through my head as well.
This V, that's good. No, I just thought I would show you guys this.
That is a vagina.
This is a
No.
This is a.
Oh yeah, no, sorry.
What is it?
I don't know.
Why are you?
You did this last time.
Come on.
I didn't have a.
What do you?
I don't know which V we're talking about. This
This
is a vagina.
No, this is a vulva.
Oh, vulva.
So
right.
everything on the outside is the vulva.
Mhm.
The vagina is
Is
this on the inside.
Right.
Yes.
Yeah.
Vagina has the word in,
In
so that tells you that it's on the inside.
inside.
Yeah,
And the
I didn't make
vulva.
it up. It's Karen Hobbs, who's a comedian who's made that up, and I love that. But nothing to be shy about.
I'm
They
more
are
shy
not
that I
bad
didn't get it
words.
right.
Oh,
Like,
my God.
no,
I'm not shy about that.
It's
Okay.
common.
I physically saw you move away from us.
Please don't ask me this question. We're editing it out. I'm joking.
Everybody needs to
But
know
yeah,
about it,
yeah,
so.
yeah.
But can I echo what this has just said, that every voice does count. And sometimes when these surveys come out asking for feedback, for example, we've got this whole thing going on in maternity right now, maternity units. Every voice does count. You might think, oh well, why bother fill out the feedback form or whatever? I'm only one person.
Yeah.
Actually, they need to hear from
Everyone.
everybody.
Yeah. Absolutely. Jess, I think it would be wrong of me not to mention the work that you're doing at the moment, because it's actually very, very important as well. Can you just tell us a little bit about the guide that you're working on and everything like that?
Yeah, so I work for NHS Blood and Transplant, and we don't have any kind of like policy for menstrual health. We have one for menopause, but we don't have a specific one for menstrual health. So we're working on a policy, but policies take time. So in the meantime, we're producing a menstrual health guide for not just for staff, but for managers, so that they know what support they can provide. And just a little bit of it is the background to menstrual health disorders and what it actually means and how it can affect a person. Because I don't think we don't talk about it enough, and it's still classed as a very much taboo subject. So it's to kind of encourage conversation, open conversation, and try and break down some of the barriers that we have, and kind of make managers more aware. I don't think a lot of managers are aware. A lot of people don't tell their managers, and there's a survey done by the CIPD. I can't remember what it stands for, sorry, but it's like a national survey that's been done about people who choose not to tell their managers because they're scared. They're worried that they're going to be kind of penalised for it. They're not going to be put forward for promotions, or people leaving their jobs because they don't feel that they have enough support, because people are telling them, oh, it's just a period, pull yourself together. So we don't want to lose our staff. We want to make sure, because when a person leaves, you lose their skills, you lose their experience, and it's just not nice. We're kind of, why should people have to leave their jobs because they're not getting the support? And that's what we're kind of working
on. So important. So important. Chartered Institute of Personnel and Development. That's right. Just in case somebody wanted to know. Thank you. And we've talked a lot about change, and this very much is systemic as much as it is on the individual scale. But and thank you for talking about some of the ways in which we can be advocating and for that change. But if there's a government official in charge of health and policy or something at the moment that is watching this or happens to watch this, what would you say to them? What would be your message to someone in that position that has a real opportunity to make change and make a difference for so many women?
Believe them. Listen to them.
Yeah.
And when they say something isn't right and things need to change, please act on it.
Yeah.
You don't need any more reports. You don't need any more reports. We know that there's an issue. We know that there's a disparity. We know that a women's health gap exists. And we know that it's worse when you add intersections. Believe them, listen to them, and please make actionable change now.
Absolutely.
It's about time.
Yeah. Well, ladies, I want to say thank you so much for joining me. And as I mentioned to you prior, I always ask my guests that important question at the end, which is how they'd like to see their social corner change over the next 5 years. The areas of society that you're really pushing for change in to challenge some of these social issues. And I just want to go round and just really get a pinpoint of, because we're all working in the same space but differently, what you really want to see happen, how you want to see it happen. And then just a little message of hope, because I think there are people who be watching this that probably, I hope, have come away so much more informed, but maybe not still feeling like, I can get through this, I can get past this. So is there a message you could share for them as well? Lorna, I think I'll come to you first this time.
Right. So my work is mainly within the Black kind of perinatal health space, so looking at Black birth outcomes. So I would love to see us in a space where, as a Black family or a Black person about to give birth, is not afraid. Because we're hearing about, 2 times more, 3 times more, 4 times more likely to die during that perinatal
That is scary.
period. I would love to see that actually not be a thing anymore, and that we can go into pregnancy and birth feeling confident that we're going to come out whole and healthy. My one message is, though, I am very privileged as a doula to see many, many, many Black births turn out just beautifully. So I will say that it's not that we're broken, and that Black birth does work. I've seen it time and time again, and I'm hopeful for improvements.
I love that. Thank you very much. Neelam.
So I think for me, a lot of our work is centered around not the policy shaping, but shaping community care. At Sisters, it's about building tangible relationships with people in settings that require collective liberation. And I think real health justice, and not just menstrual, not just maternal, but health justice generally, it needs to be done through that framework of liberation, all of us together in this together, whether it's you're somebody who's from the community that we've supported with period products, for example, or baby milk, or you're somebody who's a CEO of a company. We're all on these same sort of journey, and collective liberation, togetherness, community care for me is at the heart of it. Radical love, actually, for us, is very important. I could sit and talk to you about policies all day and how we can do that, but the reality is those things are not going to happen tomorrow. But radical love, community care, and centering each other, caring about each other, checking in with your people is actually, for me, the way that we can start to save ourselves. Because in these moments where it's been most difficult, it hasn't been the surgery that's helped, it hasn't been the tablets that helped, it's been the auntie down the road that I made friends with at a network launch, or it's been one of the sisters in the group that's said, have you thought about this, or do you just want to talk, do you want to have a coffee? Community care for us is really at the heart of it. So if I could spread a message to someone, is let's look beyond just being the advocates and being the voice, and let's be the people. Community care is everything.
I love that. I love that, community care. And I love the way you've phrased that and framed it as well, because I don't think we necessarily, I personally haven't had a term for that, because we talk about having our support group, but actually community care, that's what gets us through, because you get the touch points with the medical profession, but
it takes a village.
It takes the village to keep us going. I'll come over here now. Jess, I'm actually going to come to you next. How would you like to see your social corner evolve?
I would like to see women empowering others and not tearing each other apart. We should be standing together and openly being able to discuss these topics and not have to shy away from it. And we shouldn't just be talking them with other women, but like discussing it with our families. My son knows. Obviously now I don't have periods anymore. It's great. Since they hysterectomy me, but he knew that there's a towel on mum's side of the bed. She's not very well. He'd be like, Mum, you don't look well. You know, do you want some paracetamol? Shall I get you a hot water bottle? You know, and my husband was like, why are you telling him? Why not? That is my question. Why not? He will grow up one day. He might have a daughter of his own. He'll have a partner. He needs to be aware of this, and he needs to know that it's not something that we should be embarrassed about. Why are we embarrassed? You know, we should be openly able to discuss. And like what Aziza was saying, be our own advocates. Speak up. If something's not right, seek a second opinion, which was something I didn't do, but now something that I would actively tell everyone to do. If you're not getting the answers, you know your own body. If you're not getting the answers, you look to another doctor, move away, ask somebody else, speak to somebody for advice, reach out. Don't be scared to reach out. And I think that's probably the biggest take-home message. Don't be scared to seek advice.
Last but never least, Aziza, what about yourself? 5 years, your social corner. What do you want to see change?
You know what? Everyone's literally said pretty much what I was going to say, but one thing that I'm very, very passionate about is the destigmatization and the normalization of words. Vagina, vulva, clitoris. They are just words. Can we all say it? Everyone ready? Say you okay? Okay, ready? Everyone's gonna say vagina, vulva, clitoris, right? We'll go.
Vagina, vulva, clitoris.
They are not bad words, and this is why I'm wearing this t-shirt.
No, it's true.
That's why I'm wearing this t-shirt. I would love, within the next 5 years, for us all to be able to say these words without there being any shame, any stigma, any, because that's learned, that's intergenerational. And actually, because of the shame and stigma that's associated with it, it is costing lives. There's so many women who don't come forward about their problems because they're too ashamed of these aspects of their health, or they're shy. They're too embarrassed. They're literally dying of embarrassment. And then you have women who say things, and I've seen this, I have a vaginal lump. It's not a vaginal lump, it's a vulval lump. They don't know the names of the different parts of their vulva. They don't know the different parts of their own bodies because we've shied away. We've allowed the shame and stigma to take control of us. And most importantly, and this is why I'm really, really passionate about this. Sorry. It's okay.
Jail.
You said a bad word.
Not a page.
No, it's our children. We are doing this for our children. We're doing this for the next generation, right? Ultimately, vagina, vulva, clitoris, penis, testes, they are not bad words. They are anatomical names that we should use, and it's to protect them so that they get that confidence of those body parts and they're able to come and talk to us about any issues they may have in the area. Like my daughter knows the different parts of her vulva, so she will say to me, "Mommy, I'm having pain on the right side of my outer labia." She will say that to me, so I know exactly where to look, right? And it protects them from sexual predators. Yes. So we know statistically, research has shown that sexual predators often avoid children who use the correct terminology because to them it's like, actually they've been taught about sexuality and body safety, so I can't. And there are children, there's a story of a young girl who was trying to tell her mom that she was being molested by her uncle, but she kept saying, uncle keeps playing with the cookie, because that's the word she was taught. Given. Okay. So I'm really hopeful that, it's not going to take 5 years, but I'm hopeful that there will come a time that we remove the shame and stigma associated with all of these things, all of these conditions, so that we could save lives and protect our children, really, make a difference, make a change.
Make a difference. Well, I'm co-signing all of this because I think collectively that's how we make the difference, isn't it? Ladies, I'd like to say thank you so much for joining me. We will leave some information about where to get support at the end of this episode, and also the handles of anyone who you might want to see if you can find them on social media. We'll put them up as well. This has been not just insightful, personal, but also just, I think, really uplifting to see a community coming together and being able to speak on this and remove the shame. I think that's, one of the big things that you said today. So from my heart, just thank you very much. And I'm sure there's people watching that also will be saying exactly the same. So big thanks to you.
Thank you. Thanks for having me.